Good afternoon, everybody. My name is Calandra Park. Fortunately, it's just me. So you'll be hearing one voice for the next, 40 minutes or so. Trudy couldn't make it today. She was traveling up to Sacramento for a different meeting. All the meetings were the last 3 days. Um,
Yes.
so it's been a little bit of a juggling act over here at CDPH. So as Teresa mentioned, I'm with the Office of Policy and Planning, and I am a section manager here for the Community Health Investment and Policy sections. And we jointly are part of we meaning our team, come from those two sections, and we are the BHSA planning team. So as Teresa mentioned, we did release the phase two guide, I believe back in November. It's still up on the website, and so you can kind of do a deeper dive into the guide on your own time. But this presentation today will basically be a summary of the key points from that guide. Um, so I'm going to share my screen. I've got a lot of information to share through these slides. Let me see here. Oops. Um, so I won't be able to see everybody once I start sharing. So if anybody has any questions or are there any comments in the chat, please feel free to just go ahead and interrupt. Let's see. Okay, here we go. So that's phase one. So here's just a quick overview of the agenda. I'll give a quick overview of the guide itself, and we'll talk a little bit about funding and investments, and then talk about next steps. And happy to take questions. It says at the end, but happy to take them as they come up because we're going to go through a lot of information. And I know it's easy to kind of forget or lose track of the questions. Okay, so let's start off with a quick overview of the population-based prevention program coming out of the state with starting July 1. So just as a quick overview or quick background, the BHSA funding, the state 10% of the overall investment, so all of Prop 1 funding, behavioral health funding, 10% of that has been dedicated to the state. And of the 10%, 4% came to the California Department of Public Health. And so we are going to be coordinating and managing the statewide prevention services to reduce the risk of people developing mental health conditions or substance use disorders. And of the 4%, at least 51% of the funding must be used for folks who are 25 years old or younger. So for the 4% that we've been allocated, these prevention programs must meet the following criteria. So they do have to incorporate evidence-based practices or promising community-defined evidence practices. Some of you may be familiar with the term CDEPS. That's the community-defined evidence practice. And these programs must meet one or more of the following criteria. So they have to benefit the entire population of the state, county, or particular community. They have to serve identified populations at high risk, aim to reduce stigma associated with seeking help, serve populations that are disproportionately impacted by systemic racism and discrimination, prevent suicide, self-harm, or overdose, and really they need to strengthen population-based strategies. And just as a point of clarification, prevention funding cannot be used for early intervention, diagnostic services, or treatment for individuals. That whole domain of the work is under Department of Healthcare Services, which is our sister agency, and a lot of that is all of that is under their purview. Okay, so that's sort of the larger landscape here at the state and where CDPH falls and sort of the mandate, the charter, the vision, if you will, for the work that we're doing at the state level. So we're going to dive down a little more closely into the actual elements and components of the prevention strategy that the state is putting out. So in the phase two guide, just to give a little more background about the process, there was a phase one guide that was released back in June, at the end of June. And that really just kind of went over all of the statute. Statute it's long and very long-winded. And so we tried to simplify and make that language a little bit more accessible. We talked about the leadership structure, and we talked about just more of the organizational piece. And then about 5 months later, we released this phase 2 guide. And during that 5-month period, we integrated a lot of the public comment that we received from phase 1. And so I'll go clockwise, so starting on the left. And then phase 2 guide also includes a lot of the operational and administrative pieces that we would like to put in place to achieve the intended objectives, goals, and outcomes. As we mentioned, it was guided by a great deal of community and partner input. So in addition to the public comment, we also met with many different partners from different spaces and different groups that are working with different populations. So we also met internally, meaning, I guess you should say intra-departmental. So we met with like the CalVet team, we met with the Department of Social Services, we met with the Department of Aging, we met with the Department of, did I leave one out? Healthcare services. I mean, very closely we work with them. We also met with many like children's based groups. We met with groups that work, with particular populations. And so we really tried to have a lot of listening sessions and really hear what's going on in the ground and what priorities were elevated and bubbled up to the top. So the phase 2 guide also includes implementation activities per strategy. So we'll get into that a little bit more. And the guide really is intended to set the statewide policy directions, strategies, and opportunities that will reach at the local level. So as I mentioned, we had the phase 1 guide, then plus the phase 2 guide. We are planning to release a final plan that will encompass a lot of the content that was in both guides, but we're now going to consolidate and consider the final plan as our working document to refer to, sort of our North Star for BHSA population-based prevention. So we'll be using that to guide our work over the next 3 years. So the period for this final plan will cover July 1, 2026 through June 30th, 2029. So that's 3 fiscal years. And also this final plan aligns with, some of you may be familiar with the county level integrated planning efforts that are happening at the behavioral health departments in an effort to facilitate, more collaboration and coordination and making sure we're complementing and not duplicating or overriding or doing any of that stuff that complicates our work. And this final plan really is intended to be a living document. So we will integrate updates and revisions as needed based on data, emerging needs, issues, and we can continue to clarify different details regarding implementation as time goes on, because we know that things can come up. Okay, so these are the priority populations for strategic investment. There are some priority populations that are listed in statute, but these are also, in addition to those, we are also elevating these particular target populations. So they're in alphabetical order: Black, Indigenous, and other people of color, children, youth, and families, immigrant and refugee populations, the LGBTQIA+ population, older adults, people with intellectual and developmental disabilities, as well as tribes and veterans. The bullet there that is highlighted in yellow is highlighted because it's not in the phase 2 guide. If you were to go back and refer to that document, it is something that we added, but that we have added since as a result of much of the public comment that we received as part of the phase 2 guide dissemination. So the population-based prevention guide is in alignment with the 14 statewide behavioral health goals. So this here is sort of the statewide North Star, and these are the goals that all of us are working towards, meaning all of us, meaning CDPH, DHCS, HCI, which is formerly known as OSHPD, the Healthcare Access and Information, I think is what they're called, what that stands for. They do a lot of the workforce development work, and they also have they are also receiving BHSA funding. So these are the goals that we are all working towards. We have goals for improvement on the left and goals for reduction on the right. There are 14 So we want to improve the care experience, access to care, prevention and treatment of co-occurring physical health conditions, quality of life, social connection, and engagement in school and work. On the right, the goals for reduction are really focused on reducing suicide, overdose, untreated conditions, institutionalization, homelessness, justice involvement, and removal of children from home. And throughout all of these goals here, we are embedding and incorporating health equity as a key, as a priority. So this is just to share a little bit about alignment across the behavioral health system. And there's been a lot of discussion, some of you may be aware, around what the definition of prevention is and early intervention. And as we move from MHSA to BHSA, there are a lot of changes. But this is the Institute of Medicine's continuum of care model. And this is an infographic that we are referring to over and over again as a visual to help, I guess, align and to help sort of educate and inform folks where it is that the state CDPH's state population-based prevention work falls under. So you'll see on the left, the promotion and the universal prevention and the selective prevention really is that work that we do at the population level. And then early intervention, you see here the indicated prevention, that darkest orange triangle of the pie, and then the case identification, and we move towards treatment and recovery. But early intervention, that space right there, is all under DHCS and does not fall within the CDPH scope. So what CDPH is doing, I mean, while we're getting funding for the first time to work in this space directly from the state, I think what's important to note is that, we are building on existing expertise here at CDPH. So working in the behavioral health space is not new for CDPH. We have an Office of Suicide Prevention. There's a lot of text here, but these are all hyperlinked, and I'm happy to share the slide deck later. But we have an Office of Suicide Prevention that's been doing an incredible amount of work and data analysis, evaluation, campaign work, local level support. We have an Office of School Health that partners with education entities throughout the state to help support the health infrastructure within schools. We have a substance and addiction prevention branch that oversees the overdose prevention initiative. We also have the violence prevention initiative, which aims to reduce firearm violence and create safer and healthy communities. That was just released in August of last year. We had a convening in October. Excuse me. And then we have within the Office of Health Equity, the California Reducing Disparities Project, which basically, created a platform for folks at the community level to identify solutions that are working at the local level for historically unserved, underserved, and inappropriately served communities. And that CRDP work is what is laying the foundation and what will transition into what I called earlier the community defined evidence based practices. So CDEP, CDEPs. And then, of course, we have public health experience and expertise in areas of data and evaluation. And this is just a snapshot. There's more. We also have programs that support adverse child experiences, positive childhood experiences, and also supporting other 0 to 5 efforts within our maternal child health division. So there's a lot of work that we are building on as we move forward. And to that end, the department is planning to create a new office, and it's going to be called the Center or Office of Social and Behavioral Health. We really want to elevate behavioral health as a public health priority and provide that coordinated and centralized approach. This way, having a centralized office will help ensure leadership, alignment, oversight. There's some, efficiencies that can be created by bringing everybody together. And again, as I mentioned, really elevating public health, behavioral health as a public health priority. Okay, so we're going to get now into the very specific components of the prevention program, and there are 6 specific components. So I won't read the white boxes in the interest of time, and we'll get into them in more detail. So we have statewide policy initiatives, focused statewide behavioral health prevention strategies, statewide awareness campaigns, prevention training and technical assistance, community engagement and coalition building, and then of course the data and evaluation pillar. So there are 6 components. And then we'll go into further detail with each of these components. So the statewide policy initiative really is to dedicate resources to track emerging behavioral health issues. Some of you may be aware with, the emerging issue related to kratom and other substances that are, that are emerging, and then other behavioral health threats. We want to make sure that we have resources dedicated to track these, to research, evaluate impact throughout the state, and come up with policy recommendations in order to move forward. For example, some of you may also be familiar with AB 1282, which is about the impact of social media on youth. That was from 2024, but that is something that we are still working on in terms of tracking and having work groups throughout the state, across the state. And SB 243, which is focused on chatbot safeguards and online safety, which is from 2025. Statewide prevention strategies. So it's a broad term to really encompass an opportunity for tailored strategies to be implemented throughout the state. So again, as I mentioned before, on the left, we are trying to leverage existing plans and initiatives and the different recommendations that are contained in each of these plans. So we have the state strategic plan for suicide prevention. We have the violence prevention initiative and roadmap. Again, the overdose prevention initiative. We have the 988, blueprint. We have the master plan on aging, and we have guidance and guidance from the Substance Use and Mental Health Services Administration, from SAMHSA, which is at the federal level. So some examples, this is by no means exhaustive or recommended, but these are just examples. So lethal means safety and harm reduction, cultural and social connections, social emotional learning, stigma and discrimination reduction, policy systems and environmental change, early childhood and parenting support. And again, this is where CDEPs also come into play. The next component of the statewide prevention strategy are statewide awareness campaigns. So the approach here is it's a 2-pronged approach. So on the left, we're planning to leverage existing assets. So we have 4 campaigns that are currently very active, thriving, doing really well, and reaching the target audiences. And then on the right side, we'd also like to invest funding into developing new campaigns. So on the left, we have Never a Bother, Take Space to Pause, Live Beyond, and Facts Fight Fentanyl. And then on the right, we have new campaigns that we are planning to develop, focused on suicide and self-harm, 988, and then substance use disorder prevention. Okay, the next component will be dedicated funding for training and technical assistance. And so again, these are just examples. So this really could be anything focused on supporting and building the capacity at the local level, regional level, and seeing what the different needs are. We're also looking at what statewide approaches we can take. So perhaps these are strategies that promote pieces, positive childhood experiences. There could be a behavioral health literacy curriculum to help increase the knowledge and skills related to mental and behavioral well-being. And again, just mentioning PACEs and ACEs. So we are planning to work with some statewide entities that can deliver unique TA across the state. So we're looking at other providers that could focus on priority populations such as veterans and older adults. Okay, and then the next 2 pieces of or program components are community engagement and coalition building, and data and evaluation. So on the left, community engagement really is exactly what it says there. It's engaging with folks like you and with groups around the state, and really setting up opportunities and platforms where we can engage with folks around the state and hear what's working, what's not working, to hear different needs, being elevated. So to that end, we're developing an implementation work group. And as it says here on the slide, this work group will inform CDPH's BHSA statewide, planning, again, understanding what's happening at the local level and really be focused on designing solutions and moving forward. We also plan to develop and implement an advisory committee, and this for CDEPs. So CDEPs, as I mentioned, are the community-defined evidence-based practice programs, and we want to create a space and a community for folks to come together and talk about lessons learned, best practices, what's working, what's not working, and troubleshoot together and really create a community for those folks. Then, of course, we want to make sure that we are incorporating youth and family voice. And so there's a youth and family engagement network that we would like to engage in order to have that youth voice be a consistent and constant source of input and a source throughout all of the work that we're doing, given the 51% mandate to focus on folks who are 25 and younger. We feel that it's really important, obviously, to elevate that voice. And then on the right here, data and evaluation, monitoring and evaluation. Of course, our plan is to have a robust framework to really assess the statewide impact, right? We need to know what's working, what's not working, what's happening. We're going to align a lot of this work to the 14 behavioral health goals that I went over earlier in this presentation. So when we say align system of metrics, we're trying to align with DHCS as well as really trying to align it with those goals. We also plan to collect data, utilize data, analyze data through the lens of health equity to really see the racial and ethnic and gender, age, demographic disparities, and do our best to inform those disparity reduction efforts. So data disaggregation as much as we can to the point that it's to the point where it's feasible. That also is a priority in the BHSA space as well. Okay, so those were all of the statewide strategies, and now I'm going to dive into the local reach for some of the strategies that we are proposing. So really our approach and the framework for mobilizing local reach with BHSA funding is, at the core, we really want to see systems change. So I'm going to talk from the bottom up. At the core of the work is really systems change, right? BHSA in and of itself is intended to create that systems change. It's intended to incorporate substance use disorder into the work. So it's really an opportunity to increase multi-sector collaboration, alignment, and integration of that funding with other funding sources and access and coordinating that care. And that takes time, but that really is at the core of a lot of this work that we're doing. And then, moving on a little further outside of that, the sort of the concentric circles here, we have cross-cutting efforts. So as we mentioned at the systems change, we're trying to coordinate and maximize and leverage opportunity. Same cross-cutting efforts. We want to make sure that we're not working in silos and that we're creating synergy as much as possible, enhancing that coordination, having public health work with behavioral health, and working with schools, working with the veterans, as much as we can. Let's break down some of these silos and really start to work together more and leverage our various expertise. And then ultimately, obviously, the goal is to invest in infrastructure, right? So we want to support strong coordination across the whole behavioral health, spectrum and expand the prevention layer of that work. And so CDPH is really trying to look at it through these three key elements. So just as a quick sort of, visual tool here, population-based prevention, we've got statewide and we've got local assistance. So on the left, these are the 6 components that I just went over. And then the local assistance will be broken down into CDEPs, trusted messenger campaigns, regional policy, regional implementation. There's a tribal program, training and technical assistance, the LHJ program, and the 988 outreach program. So we'll get into these next. A lot of information. I see some chats coming in, but I don't know what they are. So we'll go over them a little later. So here we have the funding to mobilize local reach of statewide strategies and policies. So this kind of breaks down, this line kind of encompasses a lot of information at once. I apologize. I have something in my throat. I'm trying to do my best to plow through here. So on the left, CBOs and tribes would be eligible for these 5 different buckets. So we've got CDEPs, the Trusted Messenger Program, the 988 and Behavioral Health Crisis funding stream, regional policy research and development, as well as regional implementation. On the right is also training and technical assistance. And so we have these 6 priorities here that we are elevating for more training and technical assistance support at the local level, focused on older adult behavioral health, veterans, 988, other regional approaches, train the trainer models, CDEP technical assistance, and tribal engagement. Okay, so slightly deeper dive. So as I mentioned, the CDEP, I've been saying practice. Have I been saying practices? Community defined evidence-based practices program. I think I've skipped the practices and went straight to program. But in any case, so the eligibility for this funding is CBOs and tribes. And really the purpose of this is to scale and uplift the community defined, locally defined, culturally responsive practices across the state. So, California is a vast, large, diverse state with many different needs. What's happening in one community could be very different than what's happening in another community, and what's working in one community, extremely effectively. We want to uplift that. We want to support that. We want that work to be sustained and to be embedded into that local community as much as possible. And maybe there's an opportunity for another community to do similar work. So in any case, it's really about having that community defined. The goal is to reduce those historically the disparities in the historically underserved, unserved, and inappropriately served populations, as I mentioned earlier, and also just to improve access to behavioral health prevention and resiliency. So that's the CDEPs. Then the next program here is the Trusted Messenger Campaign program. So again, CBOs and tribes are eligible for this. And this is, again, just speaking to that local level tailoring and knowing that there are trusted messengers, folks that people trust and will listen to and will be influenced by and can really speak to them in a way that folks that the public can connect to. So here the purpose is really to bridge communication gaps, foster that empathy and understanding, and really respecting health information. And ultimately the big goal is to improve health outcomes in communities with these disparities.
Calandra,
yes.
did you want to take a break and have some water? You sound like
I'm doing it. It keeps coming up.
Okay.
I'm happy to take a break and answer questions, or I can just keep going.
Go ahead, just keep going if you're okay.
Yeah, I'm okay. Thank you all for your kindness. And I can't see anybody, so I'm just plowing through here. Again, this funding is open to CBOs and tribes. And this really is intended to help fill the gaps around 988. So, some of you again are probably familiar with sort of the fragmented, state of 988 right now in the state. Folks don't really know when to call. Is it 988? Is it 911? When should we call one or the other? What do we get out of 988? So we want to do a little bit more work around 988. And at the state level, there's an entire 988 implementation work group. And there was a recent assembly bill dedicated to, so there's just a lot of attention and focus and prioritization of supporting 988. So here the purpose would be to understand what the current, knowledge, attitudes, beliefs, perceptions are about accessing services. We need to understand what's happening, what's not happening, the misperceptions, the misunderstanding, and what's working, right? So it's not all broken, but we want to know where are the gaps. And so we want to know also how to tailor and be more culturally relevant to encourage 988 usage. We want to tailor the messaging. And we also want to just expand the dissemination of promotional supports for 988 as well. Okay. Another local level strategy is regional policy research and development, again, open to CBOs and tribes. And again, this really is an effort to give folks at the regional, local level to uplift those local needs and priorities that are unique to that specific area, possibly. California, as I mentioned, as we all know so well, it's a very diverse and vast state. There's there are things that happen in LA that don't happen anywhere else, and there are things that happen in Shasta County that don't happen so we really want to be responsive and give folks an opportunity to develop some policy recommendations that acknowledge and recognize those impacts in the local regional areas, focusing on stigma and discrimination reduction, as well as the promotion of mental well-being and resilience. And we also want to make sure that all of that work is contributing to those 14 BHSA statewide goals, and then talk about the real world practical steps for implementation. And similarly, there is another funding stream here for regional implementation of focus strategies. Also eligible for CBOs and tribes to apply for. And again, here it's very similar to the policy slide previously. This is really about elevating and identifying strategies that are working in the regional local level. Again, very different needs throughout the state. We want to provide an opportunity for folks to tailor efforts that are unique to the population. And we'd love to promote an opportunity for more peer learning and spread of best practices and lessons learned, and just really highlighting, again, work that's happening already or that needs to happen at the local level, regional level. And then prevention training and technical assistance funding, again, recognizing that there are different TA needs across the state that need to be addressed at that local regional level. We are offering another funding stream here eligible for CBOs, educational institutions, tribes, and other nonprofit entities. And we would like to highlight the training and technical assistance to focus on some of these specialized and unique populations, such as older adults, veterans, LGBTQ, immigrant populations, tribes, 988 crisis services, as well as other regional approaches. I might even add the IDD population, the intellectual and developmental disabilities. As I mentioned, that's a newer ad as a result of the feedback that we got from the phase 2 guide dissemination. So just opening up another arm here for funding for technical assistance at the local regional levels. Okay, and then there is, of course, there's another layer of the funding strategy dedicated to the tribal community as well as to the local health jurisdiction. So on the left, right now there is $6 million allocated for the tribal program. It's 5% right now of the overall BHSA allocation, and this is an opportunity for the tribal community to address the needs that are specific to their own communities. And to that end, we conducted 2 formal tribal consultations to help inform this process and to help shape what the logistical process would be, as well as to shape what the priorities are and how to target and elevate and prioritize the different needs in the tribal communities. So that has been a very active and rich layer of the work here at CDPH. And then on the right-hand side, we have the local health jurisdictions. So this is, there are 61 across the state, and there's $12 million dedicated for supporting the LHJs. And what we really would love to see and would like to see is that these LHJs would act as the local prevention coordinators and convene a local prevention sort of council, coalition, convening, group, whatever, it might, however it wants to be termed. And this group would really be tasked with leading the development and update of a local suicide plan. I believe there are about 15 to 20 suicide plans that are established throughout the state, but we would really want to see that happen across all of the LHJs. And so this convening or this coalition really is an opportunity, again, to bring folks from very varied backgrounds. So the veteran community, the IDD community, the youth voice, the schools, from county behavioral health, from managed care, from private sector, from anyone across the whole spectrum that is involved with this work. We would love to see everyone come together and talk about what are the opportunities, what's working, what's not working, who's doing what, how can we piggyback on each other's work, leverage the work that's being done. And it doesn't have to be a brand new coalition. It could be something that is an expansion of or a variation of a current coalition. But ultimately, we do need to see or would like to see that there is some sort of local level coordination coordinating body, convening and doing, work on a regular basis to continue to integrate and coordinate local behavioral health work. That third bullet there about the integration of local behavioral health data needs and assets into the LHJ-led community health assessment and community health improvement plans. Quite a mouthful there, but you'll see in the guide that there is a section dedicated to what we're calling the CHA chip, CHA, and the CHIP. So CHA chip process. It's a little bit too much to kind of get into right now, but some of you again may be familiar, but there is a community health assessment process that every LHJ is involved in, and soon everyone will be on the same timeline with developing with their CHA, and then 6 months later the CHIP is due, and as a part of that, this incredible amount of alignment work that is happening at the state, the county behavioral health is also developing their own integrated plans that is also on the same timeline. So you see here how strategically everything kind of aligns. There's a lot of work happening to kind of bring all of the partners, all the stakeholders to the table to do work together as opposed to separately. Oh, and of course, how could I forget the MCPs, the Medi-Cal managed care plans are also a critical piece of this process as well, because they used to do their own assessment, the PNA, and now we're trying to bring everything together. So it's a long conversation, but we're just trying to align everything, and we really want the LHJs to, again, to be that linchpin and that central coordinating body to help integrate, coordinate, and align all of this work. I probably confused everybody a little bit more with what I just said, but in any case, it's outlined in the guide, and there are a lot of hyperlinks included in there if you really wanted to do a deeper dive. Just doing a quick time check here. Okay, the tribal program, is for federally recognized tribes, Indian health clinics, and urban Indian organizations. And again, it really is intended to provide access to those crucial resources that have long been denied or, underfunded, underserved. So this gives the tribal community an opportunity to elevate and propose tailored strategies to address those behavioral health inequities amongst the tribal communities. And again, as I mentioned before, we had 2 formal tribal consultations, government to government, to formalize this relationship and to formalize the discussion and the next steps to ensure that the tribal community is engaged and informed and empowered. Okay. Oh, so there's another slide here on the LHJ role. So again, acting as conveners, the suicide prevention plans, and again, that vision for alignment. I won't go into all of I think I probably already talked around all of these points here, but you'll see some of the examples on the left for possible participants in the local convening. I think I mentioned all county behavioral health, MCPs, different CBOs, areas on aging, education, veterans, tribes, again, suicide plans, and that vision for alignment. Okay. So last few slides here, what are the next steps? I've just talked for a very long time with a lot of coughing, and I apologize, around what that phase 2 program guide and the eventual final plan will look like, and what it will, what our early thoughts are on the BHSA population-based prevention strategies. So in terms of more immediate steps, we are planning to publish an FAQ as well as a PEI, stands for Prevention and Early Intervention fact sheet. So you may recall that that pie of the IOM's continuum of prevention. There's a lot of confusion right now about sort of what's considered prevention, what's considered early intervention. A lot of that has been discussed and raised as an ongoing point of confusion. Understandably, it's very confusing. And so we have been working with DHCS to kind of put together something that we're hoping will help continue to clarify that distinction between prevention and early intervention. The FAQ that we're planning to publish is more about some of the questions that we received when we released phase 2. So there were a lot of questions that we felt like needed to be pulled out and highlighted in a separate FAQ document for just spotlight highlighting, and so we're planning to publish that fairly soon. In February, we'll be publishing the final plan, and as I mentioned earlier, that will incorporate both phase 1 and phase 2, as well as all of the recommended edits and revisions from the public comment that we received over the past, or back in November, December. And then we are planning, hoping, and working on releasing funding announcements in spring, and doing our best to have folks hitting the ground running as close to July 1st as possible. I did want to highlight, if you have any other questions or if you want to be added to the CDPH BHSA website, I would highly recommend sending an email to this address to get added to the list. We do send out a lot of updates around different so like the final plan, we would send out an email to let you know that it's been published, as well as the FAQ, the fact sheet. We do plan to send out funding announcements via this email, as well as to all of our partners. And so it's a good resource to stay connected to. And with that, I conclude the presentation, and I'm going to stop sharing so that I can see everybody. So thank you, everybody. Appreciate the time and the opportunity. I think we have a little bit of time for any questions that folks might have.
Great. Yeah, thank you. Really appreciate the information. It's exciting to see the plans coming together. I know we had one question, I think maybe it was in the chat, about if the local boards and commissions, we have 59 local behavioral health boards and commissions, and 50% of their members represent people with lived experience or that have received services for mental health or substance use, and then the other 50% may be a makeup of mostly it's all members that are in the community working in sectors that are intersecting with behavioral health. But it's an avenue to ensure the stakeholder input happens and an opportunity, for public meetings so that people can express their interests. So as you were talking about the local health jurisdictions and the coordinated maybe communications, having some types of coalitions, and you had a list of different entities, I think in order to make sure that we have the voice of family members and consumers, I think it would be good to add the local boards and commissions to that. There's nothing about us without us statement, so that might be an important, as that comes together. It sounds like that's still something that you're just thinking about.
It is, and I apologize because that list was not meant to be exhaustive. And if you look in the guide, there's a suggestion to include folks with lived experience. But certainly we can take that back as well and offer additional feedback.
Okay.
Yeah.
Okay. Yeah, thanks. All right. Question in the room.
Hi, Calandra.
Introduce yourself.
My name is Bill Stewart, and I'm the president for CALBHB, and I'm located in San Diego. Thank you for your presentation. And I only have about 300 questions.
Of course.
I'm just joking. You covered a wide range of really exciting and positive things. So my question is for the data aspect of the collection, because you also stated the range of the sizes of the counties, but also the diversity. And at times throughout our state, it hasn't always been a consistent collection of data for analyzing throughout the state. So just wanted to touch base on that, and also touch base on that 988 and in regards to the warm line. and that's it?
So your question about the 988 is just for more information, or sorry, I may have missed that. Trying to take notes and
Yes,
listen at the same time.
because the warm line was,
The warm line's different.
yes. Oh, it is? And 98?
Yes.
Thought it was connected with it. Okay, so just back to the data then.
Okay, the data and analysis, I mean, so we are still in the process of developing the evaluation framework as well as, setting up the key indicators and aligning. There are a lot of different parts, moving parts, as you can imagine. So that framework is still under development, but we are, hoping to have that released publicly, as soon as possible.
Okay, thank you.
Oh, next, yeah, another question.
Thank you so much for the presentation. My name is Samantha Berry. I'm the chair in San Diego County. I have two questions.
Mm-hmm.
One, you talk a lot about regranting to regional entities to value the local expertise and the on-the-ground expertise that we have in our counties. I'm curious how the department is looking at this, because this funding has been taken from counties in the large bucket, right, to move it back to the state. And then it sounds like it's just going right back down to the counties in lower amounts. So I'm curious, like, overarching, if you have an orientation to the benefit that it comes from the state having maybe oversight over the regranting to counties. But to me, it seems like we're just going to be doing the same things we were doing before, but receiving the funding in a different flow through and at a lower dollar amount. And I'll leave that one. And then the second part is for the local health jurisdictions, and you talked about the CHA and the CHIP, and I want to add the BHSA integrated plan, because the integrated plan is required to integrate with the CHA and the CHIP. So for your slides, just to add in the integrated plan on our 3-year plan, because we're working really hard on those at all the local level, and it wasn't mentioned as part of that integration. So I don't know if you can talk to the.
Yeah, no, thanks for your question. I dropped an integrated plan in there really quickly. It's a key part. So it's like the integrated plan plus the MCP role as well as the CHA chip. So indeed, the behavioral health integrated plan is a huge, huge undertaking, and I know they're due fairly soon. So I know it's been a big lift, and DHCS is tracking that. We're tracking that together with DHCS very closely. In terms of your question about BHSA, MHSA, the funding, I mean, the funding is coming back to the state, and it's been a big transition between from MHSA to BHSA. We're still sort of tracking that and trying to figure out sort of, how best to make sure that we're not disrupting services. I mean, I know that's going to raise flags, but disrupting services in a way that, but this is a big transition. We're incorporating, substance use disorder, and we're trying to elevate some of the more primary prevention aspects. But I think we also want to make sure that we're opening up an opportunity for some like new energy, new strategies, and more regional level approaches. And looking at ways to kind of leverage what's working and what's not working. It's also an opportunity for like the rural entities and the underserved communities to be able to propose work that's working for them, or that, that could be funded at a different level. I think also there's been, mixed reaction around the county level coordination and oversight and the Board of Supervisors involvement. So I think this is something that, has just been it's been a difficult transition for many to navigate. At a smaller amount of funding, I mean, I can't speak to that because I don't know, I think it's different depending on sort of where you are, and sort of how that was divvied up or, allocated. But I mean, the best that I can offer right now is that we acknowledge that there's a lot of that happening in the transitions, and there's a lot of misunderstanding, to be frank and candid, in terms of like folks prematurely ending some of their contracts and such. So it's been a difficult transition, and even at the state level, we're still trying to navigate that with our partners. So it's been challenging.
Thank you for the response. I appreciate the challenging nature, and I think that the local boards, we want to be partners in this transition, and it is less money for counties across the board because of the 10% going to the state rather than previously it was 5%. So counties writ large have less funding. What that means for making sure that we can scale up practices that work and share across counties for investment, totally on board with that. So thanks for that recognition, and want to be partners in that.
Yeah, thank you. Oh, another question in the room. Introduce yourself.
Hi, my name's Steve McNally. I'm from Orange County. Thanks for your presentation. On a big picture, did your landscape analysis, like I see 12 million for suicide, what do you think the 12 or 13 counties that currently have suicide plans are spending to date currently? Does your analysis include that?
I'm not aware of the local level data, but I just wanted to clarify the 12 million for the local health jurisdictions is intended to cover sort of a lot of coordinating work in addition to, and the suicide planning is part of that work.
Right. I'm just suggesting that with your landscape analysis, I was just trying to figure out what was spent locally versus what you have at the state level, and how much you're going to allocate to state funded initiatives. And are you going to put them in 11 threshold languages, or, the trusted messenger is sort of getting lost. A lot of these guys will be out of business. And so it's just something to think about. And
Sorry, I don't know if I'm following the question. I apologize. You're saying
the question is, did your landscape analysis compare your current allocation example, half maybe at a state initiative and then those other buckets, compared to what was happening and what's different? I don't know if you have that. Money's not going to, I don't think, will go very far. And I think the trusted messenger part of it, which is the most important to the person receiving services, that they want people to look like them. Those people were getting the budgets before. So that's the critical mass. And I think it would be helpful to check your awareness around the state of what people do or don't know about what's going on. But that's the big picture, just the landscape analysis of where you're spending your money and how it's going to impact patients, people, individuals, not just impressions.
Right. Yeah, no, I appreciate that question. I mean, certainly there was a lot of work and a lot of input from the various folks here at the state. So the Office of Suicide Prevention, there were different subject matter experts who brought data to the table of different findings. I don't know at the granular level what was actually compared or analyzed, but I know that a lot of that information, fed into the figures that were derived for the different allocations. So for the trusted messengers, that is something that we're very excited about, and I think a lot of folks are excited about just, elevating again folks in underserved communities and historically marginalized communities, the potential there. So this is something that we're really looking forward to.
Good afternoon, Calandra. This is Dr. Monica Caffey, San Bernardino County. I wanted to know, you mentioned the CDEP Advisory Committee. Will that be announced for people to apply to, and when?
It will be announced. I don't know when. I don't know when, but I would imagine that, as soon as the CDEPs are implemented and, the contracts are in place, we would mobilize that advisory committee fairly quickly. So all of that information we'll disseminate that under separate cover. And as soon as we have that information ready to go. Yeah.
Thank you. My second question is, many of the CDEPs who have been operating and been funded under CDPH were not aligned with county populations, and unfortunately are concerned about being eliminated. What strategies has CDPH thought about in regards to aligning their priorities just with the counties on how to preserve the CDEPs who have demonstrated, or where the community defined practices and those organizations that are actually and have been doing the work for over a decade.
Yeah, that also has been something that we have been hearing, and we are aware of the I don't want to say disruption, but the anxiety and the concern around sort of the future of, CDEPs. We did a presentation to I think it was the CDEP team or the CDEP group a few months ago, and there was a conversation about sort of not wanting to have that. I don't think anyway. There was a conversation around preferring to be directly funded by the state and having that relationship be sort of preserved in an effort to kind of keep their work independent and to be able to operate in a way that has been productive and fruitful for them. In terms of your question around like what's happening at the county level and how they can, that I think that's part of the reason why we're, uplifting their role and their involvement and engagement in that eventual local behavioral health prevention, coalition or convening, because we need to have, discourse that is all aligned a little bit better and, transparent and just working more collaboratively. Not that it hasn't been before, but I think just ensuring that there's a space for that dialogue and just really continuing to kind of, again, synergize and collaborate as much as possible. Limited dollars, for BHSA, it's a big pot of money, but it's not a big pot of money.
Yeah. Are you able to provide your email address? We have the slide for the info, but not your particular email address.
Sure. Yeah, I can add that in the chat.
Okay, I think we don't have any more questions. So thank you so much, Calandra. Really appreciate the information. I know there were a lot of tough questions, but it's a tough topic. So thanks so much. And I will share with the group the general BHSA info at email that you shared so that they can get on your regular information update list.
Great. I'll drop that in the chat as well. No, I really appreciate the opportunity and to share. And as you can, I'm sure you're picking up, we are admittedly sort of building the plane as we fly it, but is that the phrase? But we're, really doing our best to get input and feedback from folks. And Teresa, going back to your original, opening question or comment, I mean, folks with lived experience and these boards and commissions, I mean, this is who we turn to and who we want to hear from. And so I would encourage everybody here in this group to submit the public comment, to submit. We read every single word and every single one. And just to give a little bit of perspective for this last phase 2 guide, we received over, I think, 300 public comment, and our team reviewed every single one. We analyzed it, and we really elevated what was vocalized and what bubbled up to the top. And we put it all together and we share it with CALBHB, and then they share it with the governor's office. So we package it. It's important. It's prioritized. And so we value this connection with the community and with folks like yourselves. So encourage like this ongoing engagement. We encourage emails and just feedback and anything that, just helps elevate the concerns that are at the local level. We're here at the state level doing what we can with the resources that we have, but we also don't know what we don't know, right? And that's just the name of the game. So in any case, yeah, thank you again for just the opportunity to let me talk and share a little bit. If you have any other questions or points of clarification, please do feel free to reach out. It's a lot of information. It's a lot. So thank you.